شايفين السكرين؟ حد يرد عليا بس. شايفين السكرين؟
شايفين السكرين.
يا دكتور شايفين.
ايوه يا دكتور
شايفين
شايفين.
باوربوينت برزنتيشن، مش صورتي انا. مظبوط كده؟
ايوه يا دكتور شايفين الباوربوينت.
شايفين الباوربوينت. طيب ده عظيم جدا. طيب we have to start with the pulmonary embolism. We have in the last lecture discussed the DVT. DVT because of their dire complications, they are considered to be what is called life-changing disease. I like to say it is not like infection, not even like acute cholecystitis or even chronic cholecystitis, but it leaves a mark over the body of the patient, in addition carrying a certain essence of gravity. Therefore, it is very important we have first is the pulmonary embolism as a consequence of this DVT, and also we are going to discuss what is called the chronic venous insufficiency, formerly known as the post-thrombotic syndrome. To start with, we have to go with the pulmonary. We should focus over the diagnosis and treatment. First of all, what is meant by
دكتور هو الصوت فيه مشكلة؟
دكتور
نعم. حد عنده مشكلة يقول. أنا سمعت
الباوربوينت مش فاتح والصوت فيه مشكلة.
هو
الباوربوينت مش
الصوت
مفتوح.
بيقطع شوية، واضح ان النت ضعيف.
الصوت بيقطع. حد يجاوبني بس، الصوت بيقطع ولا الصورة مش واضحة؟
الصوت بيقطع،
بيقطع.
مفيش باوربوينت يا دكتور، بس الفايل بس باين، لكن الباوربوينت مفيش.
الباوربوينت ماله؟ مش سامع.
مفيش باوربوينت باين قصادنا يا دكتور، هو الفايل من بره بس.
مفيش باوربوينت باين؟
مفيش.
السكرين موجودة بس هو مقفول الفايل، مش مفتوح.
الفايل مقفول. طيب اوكي. Give me 1 minute.
ودكتور كمان الصوت لما حضرتك تبدأ تتكلم الصوت بيقطع جامد.
كده باين؟ ظهر كده يا شباب؟
ايوه
كده باين يا دكتور.
الباوربوينت باين. طيب كويس. خلاص let's go to continue. He has what's called the pulmonary embolism as a consequence of the DVT. What's meant by pulmonary embolism? Embolism means circulation in the blood of foreign material. This is called an embolus. When this embolus is lodged in certain parts of the arterial or the venous tree, it is termed embolism. In our instance, there is an embolus forms, there is a thrombus forms in the deep veins of the lower limb, and this is for a reason or another becomes detached and goes the blood stream upwards until it goes all the way to reach the right atrium, right ventricle, pulmonary artery, and then to get lodged into the vessels of the lung, the main or one of the branches of the pulmonary artery. The pulmonary embolism, by definition, is partial or complete occlusion of the pulmonary artery or one of its branches with hemodynamic consequences. This leads to hemodynamic consequences. These hemodynamic consequences depend on the size of this embolus and the location of this embolus, the size if it is big or small, whether it's pulmonary artery, which is or in the segmental arteries or the subsegmental arteries, and also the pre-existing a pre-existing cardiopulmonary reserve of the patient can withstand this event or cannot. It depends upon his cardiopulmonary reserve. Therefore, and for these aforementioned causes, the pulmonary embolism is subdivided into hemodynamic significant pulmonary embolism and hemodynamic insignificant pulmonary embolism. Again, this depends upon the size of the embolus, the location of this impaction of this embolus, and the cardiopulmonary reserve of the patient. Start with the hemodynamic significance pulmonary embolism. It presents by number one, hemodynamic instability in the form of tachycardia and hypertension, and also dyspnea, chest pain, and congested neck pains. They occur as a result usually of the large embolus obstructing one of the main pulmonary or relatively smaller embolus lodged in smaller branch of the pulmonary artery, but in the patient who has decreased or narrow cardiopulmonary reserve. Therefore, the pathogenesis of hemodynamic significant pulmonary embolism, which, as I have said, presents by hypertension, tachycardia, dyspnea, chest pain, and congested neck veins. What is the pathogenesis behind them? There is a sudden increase in the pulmonary artery pressure. This sudden increase in the pulmonary artery pressure leads to acute right ventricular failure. This acute right ventricular failure leads to ventricular dysfunction. All of them leads to reduced coronary perfusion and ultimately decreased cardiac output will supervene. And this decreased cardiac output will be responsible for the hypertension that the patient suffers. The hemodynamic insignificant pulmonary embolism has a lot of symptoms that the patients can present. For example, there may be cough, there may be hemoptysis, tachycardia, echocardiogram changes, hypoxia, ECG changes, pleural effusion, and chest pain. And as you see, all of these manifestations are non-specific to the pulmonary embolism, as they could happen with other chest and cardiac problems. For example, if the patient is having pneumonia or a congestive heart failure. And for these confusing presentations of the cases of the pulmonary embolism, in order for us to diagnose if our patient has pulmonary embolism or not, we should apply this following algorithm. If we are clinically suspecting that the patient develops pulmonary embolism, we need to confirm or to rule out the presence of the pulmonary embolism. If this probability is low or intermediate, and we will see how we calculate this probability according to this probability score. If it is low or intermediate, we should go to do the dimer testing. If it was found, if it is found to be normal, being required. If this D dimer is found to be elevated, I can go to perform to the patient diagnostic imaging, and if they are positive, we should treat this patient as pulmonary embolism. On the other hand, if the patient has a high probability of pulmonary embolism, should go directly to the diagnostic imaging. As we will see what kind of diagnostic imaging, we will see later on. If they are negative, nothing to be done. If they are positive, the patient should be treated as a pulmonary embolism. This probability score to assign the patient whether he has high probability of pulmonary embolism or intermediate or low probability of pulmonary embolism was devised by Wells. And this Wells score is being applied in clinical practice. If the patient has clinical signs of DVT, he is given a score of 3. Heart rate more than 100 is given a score of 1.5. Recent surgery or immobilization in bed more than 3 days, the patient is given a score of 1.5. Previous pulmonary embolism or DVT, 1.5. Hemoptysis is given 1 point. Malignancy is given 1 point. Alternative diagnosis less likely than pulmonary embolism is given 3. Okay, in order to remember this, we have to follow this symbol caricature. We have 2 signs. Each of them can elicit 3 points, and both can be elicited by the doctor himself. First is the clinical sign and symptoms of DVT. If they are found, the patient is given 3 points in the Wells score. If there is no alternative diagnosis to explain what the patient having other than pulmonary embolism, again, this is given 3 points in the score. As you see, the score which is given by the doctor, each of them is given 3 points. 3 others manifestations which could be elicited by the nurse. Each of them is given 1.5 points in the score of the Wells. This is tachycardia, which could be elicited by the nurse if it is found to be 100 or more beats per minute. The nurse should mark that the patient is given a score of 1.5. If the patient was immobilized in bed at least 4 days, score of 1.5 is given. If there is history of DVT or pulmonary embolism, the patient is given 1.5. The remaining groups of manifestations, each of them is granted 1 point and could be elicited by the relative of the patient himself. This is hemoptysis score of 1 or malignancy granting of another score of 1. After calculating this score, we should put the patient into high probability or intermediate or low probability. If the patient is given a score 0 to 1, this is low probability. 2 to 6 is intermediate probability. More than 6 is high probability. And we should apply the algorithm afterwards. What about the investigations is being done or for the patient who is having the pulmonary embolism? First, the D-dimer testing, as we have mentioned before, if this D-dimer test in the low intermediate probability pulmonary embolism was found to be negative, this rules out the presence of pulmonary. But if it is positive, it does not rule out pulmonary embolism, and it has no role at all in high probability embolism. Therefore, this D-dimer is considered to be good negative test. It is negative in case of low probability, high or intermediate probability pulmonary embolism. This is enough to rule out the presence of pulmonary, but it has not the same rule if the probability of the patient is high. For example, if you have patient with high probability of pulmonary embolism.
دكتور معلش صوت حضرتك بعيد قوي.
صوتي بعيد يعني ما سمعتوش
ايوه كده
كل اللي
كويس
فات
قوي.
ده، ما سمعتوش كل اللي فات كده احسن.
هو
كده أحسن.
الصوت بيقطع يا دكتور.
لا يا دكتور، هو بيقطع جامد قوي يا دكتور.
الصوت بيقطع
طب
مش بعيد.
استنوني اوقف شويه اشوف alternate access للانترنت. استنوا شويه، استنوا لحظه. طيب الصوت كده احسن؟ الصوت احسن؟
يا دكتور كده احسن كتير.
احسن يا دكتور.
طيب شايفين ويتش سكرين؟ شايفين الباوربوينت برزنتيشن؟
يا دكتور
يا
تمام.
دكتور بتاعت
يا
investigation.
دكتور ممكن حضرتك
طيب كويس.
تبدأها تاني يا دكتور الانفستيجيشنز من الأول.
هقول الحته دي تاني. الانفستيجيشنز to be done for case of pulmonary embolism. We have D-dimer testing, which is performed by blood sample, so it is one of the laboratory tests. And the second is the imaging techniques. To start with, D-dimer has no role for the diagnosis of pulmonary embolism if the probability is high. And again, this probability is calculated through the probability score of Wells. العالم اللي اخترعه اسمه ويلز سكور. طيب how this D-dimer being applied in clinical practice? If I have a patient with low or intermediate probability pulmonary embolism, I should go first for the D-dimer before imaging. Before I go to imaging, I should do for this patient D-dimer testing. If this D-dimer test is found to be negative, this is rules out in this case the presence of pulmonary embolism. And if it is positive, I should go to imaging techniques.
بيقطع جامد يا
Can
دكتور.
deduce from this D-dimer is a good negative test. It can exclude pulmonary. يقطع برضه. طب اعمل ايه بقى؟ دي يا شباب سامعين؟
بيقطع يا دكتور بيقطع.
دكتور
بيقطع
حضرتك
يا
ممكن
دكتور.
تقفل الكاميرا علشان الصوت يبقى احسن.
الكاميرا عشان الصوت يبقى احسن. طيب this is good idea. طب لحظه واحده بس، هو انا سامعكم كويس، دي غريبه برضه.
احنا بنسمع حضرتك كويس شوية وبعد كده بيقطع، بيفضل يعمل كده.
طيب انا قفلت الكاميرا هو المفروض. I hope ان الامور تبقى احسن كده. طيب تمام كده؟ سامعين؟
تمام
سامعين؟
سامعين يا دكتور.
عايزيني اعيد من فين؟ من اول فين؟
احنا وصلنا للدي دايمرز.
فين في الدي دايمر؟ ما انا قلت كلام كتير قوي في الدي دايمر. طيب
ان
المهم
هي
الدي دايمر
good negative test.
is good negative test. Is good negative test in which type of probability? Of the low and the intermediate probability. So if it is negative in the low or intermediate probability, this can rule out pulmonary embolism confidently. But in the high probability, it has not the same value. It hasn't the same value. خلاص? This is clear. Should go to the imaging techniques. The imaging technique, first of all, is the duplex ultrasound. Duplex ultrasound does not diagnose the presence of the pulmonary embolism, but it should be performed in order to diagnose the presence of the DVT, which is the precursor of the pulmonary embolism. سامعين كده ولا لا؟ ماشي الحال. أكمل؟
دكتور.
كمل؟ طيب تمام. الترانس اسوفجيال or transthoracic echo. as you know الايكو كارديوجرام دي اللي هي الموجات الصوتيه على القلب can be performed يا transthoracic يا اما transesophageal or transesophageal echo. Transesophageal is more comprehensive. It includes more data about the patient more than the transthoracic. Any of them can be performed for the patient with pulmonary embolism to support the diagnosis of the pulmonary embolism, but more important is to find if there is right ventricular strain in such cases. This right ventricular strain is, if it is found in the transesophageal or transthoracic echo, it has a prognostic value. What I mean by prognostic value? It has relation to the incidence of the mortality of the patient. These two tests, which is the VQ scan and the CTPA, are direct diagnostic for the presence of the pulmonary embolism. VQ scan uses the technetium, which is a radioactive isotope that emits gamma rays, and xenon, which is inert gas. The patient is injected by this technetium and is given this xenon to inhale this xenon, and the gamma rays is recorded by gamma camera. This is called the VQ scan. How we diagnose the pulmonary embolism? We diagnose the pulmonary embolism by the finding of perfusion defects in a well-ventilated area. Again, this sentence you should know. And you should memorize this, you should hold in your memory this sentence. For the diagnosis of the pulmonary embolism, you should find in the VQ scan the presence of perfusion defect in a well-ventilated area. This is termed perfusion ventilation mismatch. The normal area should have blood supply and should have air at the same time. If there is a mismatch between the air and the perfusion in the form of perfusion defect in a well-ventilated area, this is diagnosed the pulmonary embolism with high probability. CTPA consumes contrast material injection, and then the patient is and the CT is performed. We will see how it could be. This CT pulmonary artery or pulmonary angiography has supplanted the VQ scan. Nowadays, we order to the patient directly CTPA, but the VQ scan is reserved for the patients with renal impairment in whom the contrast material, nephrogenic contrast material, cannot be tolerated by the renal impairment patient. This could be a site of question in the exam, when to perform a VQ scan, or what are the contraindications for the CTPA. Contraindication for the CTPA will be the presence of renal impairment. It is the same. It is the same indication for the VQ scan. The question, in other words, what are the indications of the VQ scan? VQ scan is indicated in the patients with renal impairment. How it looks like in this. This is what's called.
معلش انا في حاجه ما فهمتهاش.
اتفضلي.
هو دلوقتي انه الرينال امبيرمنت دي كونترا انديكيشن مش انديكيشن صح؟
كونترا انديكيشن فور CTPA. الكونتراست material, iodonated contrast material, are nephrotoxic. If you give them to patients with renal impairment, these patients can develop acute renal shutdown called contrast-induced nephropathy. Contrast-induced nephropathy.
تمام بس هي انديكيشن عادي للفي كيو سكان صح؟
If you find a patient with renal impairment, and at the same time you are suspecting this patient has pulmonary embolism, we should perform to the patient VQ scan.
Okay.
The contraindication for CTPA is the indication to perform VQ scan.
Thank you, doctor.
Right. The photo, the image in front of you is the transverse cut. Transverse cut in the CTPA, which shows this is the lung field, this is the chest wall, this is the ribs, as you see, this is the skin, this is the muscles of the chest, and this is the region of the heart. This is the main pulmonary artery. This is the ascending thoracic aorta, and this is superior vena cava. The main pulmonary artery divides into right and left pulmonary artery. Notes the presence of hyperdense material inside of the pulmonary artery bifurcation. Straddle this bifurcation, and this is called saddle embolus, causing occlusion of the main right and left pulmonary artery. And again, this is the pulmonary trunk. This is a transverse cut at the level where the segmental branches take off from the main pulmonary artery. Notice this. This is the hypodense material present. This is indicative of the presence of embolus inside of the pulmonary artery branches. And also the arrow on the left side is pointing to another hypodense area in the in the segmental branch of the left pulmonary artery. This photo during surgery, which is called pulmonary embolectomy. This is the pulmonary artery. Main trunk is opened here, and this is the pulmonary embolus. See that the axis is patient is through median distribution. It is the standard. Here is same patient with the pulmonary embolus been retrieved from pulmonary. سامعني ولا لا؟
دكتور الصوت بعيد.
سامعين ولا لا؟ مش
صوت قطع يا دكتور.
الصوت بعيد أوي يا دكتور.
سامعين؟
صوت حضرتك
والله أنا
بيقطع.
لا يا دكتور الصوت بيقطع جامد يا دكتور.
طب أعمل إيه بقى؟ طيب أنا في مكان كويس، شبكة كويسة. أنا شلت من على الواي فاي وحطيت على على الداتا بتاعت الموبايل. مش عارف. طب ما سمعتوش لغاية فين؟ ما
السلايد اللي
سمعتوش
فاتت يا
لغاية
دكتور.
فين؟
السلايد اللي
سمعنا
فاتت
لغاية الامبوليزم
ما
اللي
سمعناهاش.
هي كانت في الأرض.
نعم، الإمبوليزم ماله؟
السلايد اللي قبلها يا دكتور.
السلايد. طيب حاضر. شايفينها كده السلايد دي؟
يا دكتور باين.
ايه اللي باين في السلايد دي بقى؟ اللي باين في السلايد دي أولا this patient is subjected to what's called pulmonary embolectomy. How we do the pulmonary embolectomy? We open the sternum like you do an open heart. We put the patient on cardiopulmonary bypass machine. We open the pulmonary trunk, and this is the embolus as you see. This is the lung of the patient. سامعين كده كويس؟
يا دكتور.
تمام. لو حد ما سمعش interrupt me please. Okay. This is the same patient. This is the same patient, and this is a pulmonary embolus has been removed from his pulmonary artery. It represents perfect cast of the iliofemoral veins, as you see. This is as if there is a cast inside this. This is a perfect cast of the iliofemoral vein. How we treat the patient with pulmonary embolism? We treat the patient with pulmonary embolism according to his presentation. If the patient is hemodynamically stable, fortunately, most of the patients with pulmonary embolism presents by this way. The treatment of this patient is by anticoagulant. It's by what? It's by anticoagulant. Anticoagulant, what type of anticoagulant?
الصوت قطع يا دكتور.
طيب التريتمنت بتاع البالمونري embolism if this patient is hemodynamically stable, which fortunately the most of cases of the pulmonary embolism are hemodynamically stable, this patient is given a treatment in the same way as that of the DVT, but with extended period of treatment. We give the patient mostly for the anticoagulants for 1 year, either by, as we presented to you in the lecture on the DVT, unfractionated heparin and vitamin K, or low molecular weight heparin and vitamin K, or fondaparinol with vitamin K. This is the treatment of hemodynamically stable patient. In case of the patient is hemodynamically compromised patient, the treatment should be, in addition to the anticoagulant at a reduced dose, details of which is not belonging to your scope, these patients are giving what's called systemic thrombolysis. Systemic thrombolysis, like the recombinant tissue plasminogen activator, is given to these patients through a central vein to the patient to bring about the lysis of the embolus that had been lodged in the pulmonary vessels. This is in case of hemodynamically compromised patient. If this hemodynamically compromised patient has a contraindication to thrombolytic therapy, this happens in case of, for example, recent surgery. If this patient has a recent major surgery, the site of this surgery could bleed again if this patient is given systemic thrombolytic therapy. Therefore, thrombolytic therapy in this event is contraindicated. If we found in the patient who is hemodynamically compromised, and at the same time this patient has a contraindication to the systemic thrombolysis, the patient is treated by catheter-based thrombus removal, either by suction or fragmentation. Again, hemodynamically stable patient is given anticoagulants in the same way, but at extended periods, similar to that of the DVT. The patient is hemodynamic compromised, is given systemic thrombolysis. If there is contraindication to the systemic thrombolysis, like recent surgery, this patient is offered catheter-based thrombus removal by fragmentation or by suction. If the patient is rapidly, if the patient has systemic thrombosis deteriorating, this patient is offered pulmonary embolectomy. Removal has a time to work, or systemic thrombolysis also has about 2 hours to have an effect. And if the patient is rapidly deteriorating, this patient is giving pulmonary embolectomy. Again, hemodynamically stable patients giving anticoagulant in a similar protocol to that of the DVT, but at an extended period. The patient is hemodynamically compromised, this patient is giving systemic thrombolysis. There is a contraindication to the systemic thrombolysis. The patient is giving a catheter-based thrombus removal, either by suction or by systemic thrombolysis. If the patient is hemodynamically compromised, this patient is given systemic thrombolysis. If there is contraindication for the systemic thrombolysis, this patient is given catheter-based thrombus removal. If the patient is rapidly deteriorating, this patient cannot withstand the time required for systemic thrombolysis to work or the catheter-based thrombus removal to be performed. This patient is offered pulmonary embolectomy. We reached the end of this pulmonary embolism. حد عنده أي سؤال about this pulmonary embolism؟ حتى لو عايزني أعيد حتة يقول.
الويلز سكور
دكتور
يا
بس ممكن
دكتور.
سؤال؟ انتوا المرة دي اللي صوتكم بيقطع، مش سامعكم.
كنت عايزة أسأل يا دكتور معلش على الويلز سكور.
شباب، الويلز سكور، يس.
it should be memorized برضو، ولا زي السكورز بتاعت ال DVT إن هي تبقى معانا وإحنا اللي هنديسايد؟
لا، هي برضو انت should print it out. You should decide according to that. Nothing should few things should be left for recalling. Otherwise, you should print them out or put them on your phone. برضو تاني لو حبينا نسأل على الحكاية دي هنسأل عليها برضو على principle. مش هنسأل بيها على الديلز بتاعت بيتقري ازاي. لا احنا هنسأل ممكن السؤال يجي ازاي. نقول ال probability of pulmonary embolism. How you judge about the probability of pulmonary embolism. قول لي بالويل سكور او يبقى في اجابه مكتوب فيها الويل سكور.
طيب دكتور معلش،
اتفضلي.
انا بس ممكن اعرف السكورز اللي اقدر اقول ده لو ولا مودريت ولا هاي probability؟
ما احنا قلنا احنا عندنا في 2 points 2 things او 2 signs and symptoms دول موجودين عند الفيزيشن عندك انت. كل واحده فيهم تاخد 3 points. بعد كده في 3 تانيين symptoms او signs ده النيرس هي اللي بتطلعهم. كل واحده فيها 0.5 points. في اخيرا 2 دول عند تقدري تجيبيهم من الريلاتيف بتاع البيشنت اللي هم الهيموبسيس او كان عنده مالجنس. كل واحده فيهم تاخد لو intermediate probability more than 6 very easy to be applied.
طب دكتور
كده
دكتور، هو لو العيان دي دايمر بوزيتيف على طول بنبدأ نعالجه كبلمونري امبوليزم ولا لازم نعمل له ايميجنج؟
بص تاني ده لازم يتحط في الكونتكست بتاعت البروبابيليتي. العيان ده انا اصلا مش هعمل له دي دايمر الا لو كان لو او انت صح كده. الحاله دي لو انا عملت له دي دايمر وطلع لو او وهو كان لو او انترميديت بروبابيليتي وطلع الدي دايمر ده نيجاتيف، انا مش هسبجكت البيشنت لايرايزنج راديشن وكونتراست ماتيريال بتاعت السي تي بي اي. طيب لو هو العيان ده نفسه اللي هو عنده لو او انترميديت بروبابيليتي ولقيت الدي دايمر هعمل له دي دايمر، لقيت الدي دايمر بتاعه طلع نيجاتيف، انا مش هعمل حاجه. طلع بوزيتيف I should go for pulmonary for CT pulmonary arteriography اللي هو CTPA. طيب لو هو العيان من الاصل هاي probability I should go for CTPA من الاصل من غير ما اعتمد على الدي دايمر ولا اضيع وقتي في انه الدي دايمر يطلع. ليه؟ لان هو مش المفروض يفيدني في الحاله دي. لو طلع حتى نيجاتيف في هاي probability patient I should discard this value. I should not take it into consideration. تمام كده؟
البروبابيلتي منين؟
فندم؟ عيد السؤال تاني.
ازاي البروبابيلتي بتاعتي؟ بحدد
مش
البروبابيلتي
سامع
بتاعتي
السؤال.
ازاي؟
البروبابيلتي البروبابيلتي بتتحدد بحاجه اسمها الويلس سكور. الويلس سكور ده قال في عندنا حاجتين الفيزيشن بيطلعهم كل واحده فيهم تاخد 3 نقط. في 3 حاجات بتطلعهم النيرس كل واحده فيهم تاخد 1 بوينت. ده بياخد بوينت عشان تو ميمورايز. يعني فور اكزامبل الاثنين اللي بيطلعهم الريلاتيف هم والمالجنسي دول ممكن ناخدهم من الريلاتيف. خلاص كده.
يعني مثلا كم بوينت مثلا ياخدها علشان اقدر اقول ان ده هاي probability، او كم بوينت ياخدها عشان
اجاوب. انا هجاوب. انا قلتها من شويه لزميلتي هي قلتها من شويه.
تمام.
صوتكم بيقطع، في صوت بيدخل علينا في النص انا مش عارف يجي منين. المهم يعني انا قلتها لزميلتك من شويه بس اقولها لك تاني. 0 and 1 from 2 to 6 this is intermediate probability. more than 6 this is high probability. سهله خالص ما فيهاش اكتر من كده.
طب يا دكتور امتى السيستميك ثرومبوليسيس بيبقى كونترا انديكيتد؟
لو البيشنت ده عامل لو البيشنت ده عامل ميجر سيرجري يبقى كونتر انديكيشنز because the operation field كان بليد. ليه كان بليد؟ لان هو كل اللي حصل سيلينج فيه اثناء العمليه ده بالبلاك كلوتس هتبقى ديزولفد. العيان هيبليد من الاوبريشن سايت، وطبعا عشان يبليد من الاوبريشن سايت يبقى ده could be fatal. فعشان كده it is contraindicated في الريسنت سيرجري. حد عنده سؤال تاني؟ عايز ادخل على موضوع تاني.
VQ وال CTPA في واحدة منهم more specific sensitive أو time consumption يبقى فيها أقل. Like should I prefer one over one?
Yes, the preference is for the CTPA because it is rapid, readily available, sensitivity and specificity is high. But VQ scan is time consuming, is not readily available everywhere, and its specificity, not its sensitivity, its specificity is lower than the CTPA because it can give false positive results if there is a pulmonary problem in the patient. حد عنده سؤال تاني؟ سامعيني اصلا ولا لا؟ حد عنده
سامعين
سؤال
حضرتك يا
قولوا
دكتور.
لا او عايز انقل على موضوع تاني. طب انقل على موضوع تاني.
طب دكتور انا عندي سؤال بس.
اتفضلي.
هو ايه الفرق ما بين الكاثيتر بيزد ترومبس ريموفال وبالمونري امبوليكتومي؟ يعني ايه الفرق بينهم؟
الكاثيتر بيزد impulse removal by suction of fragmentation is performed through percutaneous route. يعني ايه percutaneous route بالبلدي كده؟ اللي بنعمل ايه؟ بندخل في الكومن فيمورال فين percutaneous بسكين بانكتشر، مش بنوبن حتى. وبعد كده all instruments بتاعتنا بتدخل من جوه الكومن فيمورال فين up to the iliac inferior vena cava up to the right atrial pulmonary artery until it reaches the area where the is lodged and suction or fragmentation is ده البرنسبل بتاعتها. البلمونري embolectomy, this is an open surgery which necessitates general anesthesia, necessitates good preparation of the patient, but because it is performed on an emergency basis, so it has its own morbidity and its own mortality. Sternotomy is performed. The function are taken cardiopulmonary machine. Cardioplegia is offered to the patient, and then the pulmonary artery is opened, and this thrombus or embolus is removed. The pulmonary artery is repaired, and the chest is closed. This is the principle of the pulmonary embolectomy. تمام كده؟ وصلت؟
تمام شكرا يا دكتور. بس هي كده only indicated if the patient is deteriorating بس.
Yes, the patient is deteriorating rapidly. There is no time for the thrombolytic therapy to be to work or to prepare for the suction of the pulmonary catheter to put a catheter-based embolus removal. Usually, it is performed on emergency basis.
تمام شكرا يا دكتور.
العفو يا فندم. طيب هنشوف حاجة تانية كمان نعملها. ما تقولوليش إن أنتوا زهقتوا عشان إحنا عايزين نخلص الحاجات اللي ورانا بليز. طيب في very interesting topic اللي هو prevention of the pulmonary embolism. أول أتأكد إن أنتوا شايفين السكرين بتاعتي ولا لأ؟
يا دكتور.
شايفينها يا دكتور.
طيب البريفنشن اوف ذا بالمونري امبوليزم هو يوجوالي احنا لما بندسكاس البالمونري امبوليزم ونقول بريفنشن اوف ذا بالمونري امبوليزم احنا بنقول بريفنشن اوف ذا بي تي اي. بي بالمونري امبوليزم وتي اللي هو البالمونري ثرومبو امبوليزم. ما بنقولش بالمونري امبوليزم ونسكت، دايما بنحب نقولها، نقول بالمونري ثرومبو امبوليزم. بما انه بالمونري ثرومبو امبوليزم واحنا عايزين نعمل له بريفنشن، يبقى وانه الدي في تي از the forerunner of this pulmonary embolism, يبقى it is prudent to include prevention of the DVT. يبقى if you want to prevent occurrence of the pulmonary embolism, you should prevent in the first place the DVT. Okay, so prevention of the pulmonary embolism, it is better to be termed prevention of the thromboembolism, and this means prevention of the DVT and its consequence or its dire consequence, which is the pulmonary embolism. Okay. Let's see this. The embolus forms usually in the deep veins of the leg, and it travels the whole way. This the veins, and it goes each way as has the inferior vein.
مفيش صوت يا دكتور، مفيش صوت خالص.
دكتور صوت حضرتك مش مسموع خالص.
Means terms sudden it is preventable. It is preventable through the implement of what's called the prevention of the pulmonary thromboembolism. سامعيني كده ولا ايه الاخبار؟
كل اللي فات ما سمعناهوش يا دكتور بعد اول سلايد.
يعني الفيديو اللي شفتوه ده ما سمعتوش عليه حاجة؟
لا
خالص.
طيب.
لا يا دكتور.
اللي كنت بقوله على الفيديو ده انه thrombosis forms in the deep veins of the lower limb and it travels. This could be fatal. زي ما احنا قلنا من شوية ان هو if it is big and there's of the pulmonary artery in a patient, particularly in a patient with decreased, this patient could die, and this death could be sudden death if it is big enough to include a big proportion of this pulmonary vessels, as we have explained on the section of the pulmonary embolism. But this, all of these problems, the good thing in it is it is preventable. Preventable through what? Through applications pulmonary ودكاتره جنرال براكتيشنر، وهتقف حاجات كتير قوي اللي اعمل له بريفنشن للبالمونري. ازاي اعمل له بريفنشن للبالمونري امبوليزم؟ كل الحاجات دي لو انت if you are in doubt you should consult vascular surgeon or hematologist about this specific topic علشان خاطر نعرف how to behave in such way or take decisions in such instances. We should answer this question will constitute what is the how we can proceed with that. Case of embolism prophylaxis. How do we choose? We choose among the available methods. when should prophylaxis be applied if انت العيان وانت ما تقولوش how long should I this يعتمد على availability about the use of the anticoagulants and other preventive methods. Therefore, the patient's individual risk factor to develop pulmonary thromboembolism should be weighed against the consequences of any of the prophylaxis methods. For example, anticoagulants. As we know, an inherent complications in it, which is the bleeding. If the bleeding risk is less risk for development of the pulmonary embolism, this patient should be given anticoagulant. I'm explaining the idea. This is not solid rules. This is to explain the idea behind the VTE prophylaxis. Also, the available prophylaxis method within the hospital. You may want to apply certain methods, but certain method is not available in your hospital. So you should choose among the available facilities you have. Why should VTE prophylaxis be applied؟ صوتكم طلع فجأة كده في صوت دخل كده من بره، ده صوت مين؟ شباب سامعيني ولا لا؟ سامعيني ولا لا؟
كمل. سامعين حضرتك يا دكتور.
يا شباب لا كده انا ده منين؟ طيب المهم يعني ما اعرفش انتوا سامعين زي انا سامع ولا انا بسمع حاجات مش عارف. why should it is the leading cause of death in the United States, and as I have said earlier, we have no registry for that, but some of the countries like the US has a registry and explained that there is a leading the VTE is the leading cause of death in United States. VTE mortality is 5 times that of breast cancer and AIDS. 900,000 of the patients develop VTE, 600,000 develops non-fatal, and 300,000 patients develop VTE-related death. 2/3 of them develops non-fatal, and 1/3 of the patients develop VTE-related death. 1/3 of the VTE-related death occurs after hospital discharge. The patient is in hospital, subjected to surgery, and this patient is being discharged. 1/3 of this death occurs after hospital discharge. 1/3 of all VTE-related deaths presents as sudden death, as I have said to you earlier. 1/3 of all as a sudden death, and you can not save these patients. 4% of about 200,000 patients with non-fatal VTE develops pulmonary hypertension. حال الشباب سامعين؟ الصوت واصل؟
يا دكتور مع حضرتك.
طيب ماشي. Why should VTE prophylaxis be applied? Patient who develop DVT and subjected to surgery. ليه احنا كمان المفروض ان احنا نمنع حدوث الفينا ثرومبوزس؟ الفينا ثرومبوزس لوحده عنده in addition to the pulmonary embolism عنده problems تانية. البروبلمز تانية who develops DVT and subjected to surgery. Patient عنده all DVT and is going to have a surgery, could be emergency surgery or could be elective surgery. Which type of, whatever the type of the surgery, the patient will subject to have an end or not a pristine vein. are not another event of DVT. Again, if the patient has DVT, and if we have 100 patients with DVT, 1/3 of these patients with DVT will develop severe form of post-thrombotic syndrome, and 2/3 of the patients will develop mild form of that syndrome. زي ما قلنا في اول المحاضره خالص ان انا كنت بقول انه ال presence of or occurrence of the DVT is life changing disease. It's unlike many of the diseases you know. If the patient has acute cholecystitis, after cholecystectomy the patient will be normal. But here no, if the patient has a DVT, he will suffer most of the rest of his life. الوقاية خير من العلاج عشان كل الأسباب اللي سابقة دي، سواء البالمونري embolism أو ال deep vein thrombosis itself, we have to offer what's called prevention to the pulmonary thromboembolism اللي هو prevention of the deep vein thrombosis, prevention of the pulmonary embolism, and prevention of the pulmonary embolism. طيب whom should deserve VTA prophylaxis؟ مين اللي اديهم؟ يعني it is imprudent or it is illogic to give the prophylaxis against DVT to the general population. It is not logic. It is not feasible. Even could be hazardous if you do so. But you have to focus on the patients who are at higher risk than others to develop venous thrombosis and pulmonary embolism, to give them your attention and give them the prophylaxis against pulmonary thrombosis. Under the section of the or the lecture of the DVT, we have discussed that for the thrombus to happen, there is Virchow strat, endothelial injury, hypercoagulability, state, and stasis. In addition to that, we should focus on the following independent factor. What we mean by independent factor, each factor can work independent of the other. If the age is above 60 years, this puts the patient for further risk of development of DVT than the younger patient. If the patient has previous VTE and or positive family history of venous thromboembolism, a patient who suffers from active malignancy, if the patient is subjected to anesthesia more than 2 hours, or if the patient is confined to bed more than 3 days. The risk of the development of the DVT is parallel to any of the above mentioned factors or the before mentioned factors, but we have the surgery as a key exposing risk factor. Key exposing risk factor is present in case of the surgery. And certain types of the surgery have their certain risk. For example, this surgery around the hip, like the hip arthroplasty, hip replacement therapy, total knee replacement, and hip fracture surgery are on top of the list of the high risk surgery for the patient to develop DVT, as you see. In order to identify the patients who are at higher risk of the development of venous thrombosis and pulmonary thromboembolism, it is not a matter of guess. We have to apply what's called risk assessment model. The most commonly used risk assessment model is that of the Caprini risk assessment model. Again, this risk assessment you cannot hold it by memory. You don't need to recall it. Just you need to print it out and you can apply it for each patient. Each of this have one point, and then this Caprini score is calculated to see if the patient is at which type of risk or what grade of risk the patient is subjected to develop venous thromboembolism. What are the methods of the VTE prophylaxis? The methods of the VTE prophylaxis have general measures to be applied for every patient, and we have specific measurements to be applied. General measures, the good hydration is one of the general measures. Analgesia, to have the patient to move in bed and to be ambulant shortly after surgery, is of great importance. And to perform flexion extension while he is in bed. Also, the leg elevation decreases the edema and decreases the stasis, and early ambulation, of course, are of a great importance for the patient to prevent pulmonary thromboembolism following surgery. Specific measures we have the mechanical methods. These mechanical methods, graduated compression stocking, intermittent pneumatic compression, and foot pump, and also we have a pharmacological low molecular weight hybrid. This is what are the methods of the VTE prophylaxis, generally speaking. To which patient should I give? We will see, and it will come up next. Mechanical methods, all of them works to prevent stasis, maintain linear blood flow, and prevent venous dilatation. To prevent stasis of the blood inside of the vessels, because stasis is stagnation of the blood inside of the blood vessels. This will increase the concentration of the clotting factor relative to the time passed. Therefore, these clotting factors will be present at the site at higher concentrations than any time before. Number two, to maintain linear blood flow, and as you know that the blood is not moving inside of the vessel as a one column. It has a linear blood flow, the plasma outside, and the cells, red, white, and platelets, are occupying the mid lamina or the midstream of the blood vessels. If this is disturbed, the blood element will come in contact with the endothelium, and they may interact with this endothelium, and a thrombus will form. Also, mechanical methods will prevent venous dilatation. This venous dilatation could lead to intimal injury, and this intimal injury can incite or stimulate or start method or some sort of some process of سامعين لغايه كده ولا ايه؟ يا شباب سامعين؟
يا دكتور.
سامعين ولا لا؟
ايوه دكتور سامعين.
يا دكتور سامعين حضرتك.
Okay, thank you. Graduated compression stocking, which are used to prevent the formation or حاجة يقول.
دكتور انا كان عندي سؤال بس. هي مشكله الفينس دايليتيشن في الانتمال انجري، ولا ان هو بيعمل مشكله في الفالفز نفسها، يعني بيوسعها ما بيخليهاش تقدر تقفل كويس يعني؟
لا هي المشكله كلها ان هو ممكن يعمل انتمال انجري. ما تخلطش ما بين الفينس دايليتيشن as a consequence of events واللي انا بتكلم عليه في البريفنشن بتاع الدي فين ثرومبوزس. احنا بنتكلم على عيان اكتر ناس بيحتاجوا prophylaxis against venous thrombosis and pulmonary embolism هم الناس اللي هيبقوا will be subjected to surgery. واحده حامل وهتولد، واحده كبيره في السن وهتغير مفصل، وهكذا. طيب الناس دول ممكن ان احنا offer them mechanical methods to prevent the occurrence of this DVT. طب how these mechanical methods work? It works by number one to decrease or to prevent stasis. Number two to maintain a laminar flow of the blood. Number three to prevent venous dilatation. طب النقطة اللي انت كنت بتتكلم عليها اللي هي الفينوس dilatation. طب لو الفينوس dilatation حصل في الحالة دي هيحصل امتى؟ هيحصل والعيان during surgery او بعد after surgery نايم ما بيقومش وفي stagnation of the blood يحصل venous dilatation المسل بامب ما بتشتغلش عشان تعمل venous return يقوم يحصل accumulation of the blood في lower limbs يحصل venous dilatation يحصل intimal cracking يقوم يحصل على طول stimulation of the coagulation cascade with the development of venous thrombus. واضحة كده clear؟ Is it clear؟ تمام. one of the mechanical methods اللي احنا بنتكلم عليها اللي هي ال graduated compression stocking. GCS graduated compression stocking usually which we use or always with what we use during surgery the thigh length which traditionally calls above the knee compression stocking. It exerts compression stock reaching 20 millimeter mercury. This is class 1 as I have said before. Class 1 from 20 which is commonly used after DVT and class 3 exerts pressure of 40 to 50 millimeter mercury. This is called the class 3 and it is used in cases of the lymphedema. Here to prevent the development of the venous thrombosis during surgery, the patient should wear this graduated compression stocking which is of class 1. This means it exerts pressure of 20 millimeter mercury. The advantages of this graduated compression stocking, it can be combined with anticoagulants in high-risk patients to increase the level of the prevention, as we will see. But it has a drawback in the skin irritation and could lead to ulceration of the skin as well. The intermittent pneumatic compression is the second type of the mechanical prevention. Simply how does it work? Number one, this is the most effective of the mechanical methods. Number two, it exerts pressure of 35 to 55 millimeter mercury, 14 seconds every 1 minute. It should be used during hospital admission, during surgery, and after surgery until the patient resumes his normal ambulation. Is useful in the patients who are at risk of the bleeding complication and when anticoagulants are contraindicated. Again, this intermittent pneumatic compression, simply it helps by improve the drainage of the blood from the lower limbs before, during, and after surgery. It is very effective, as you see. Its importance can be combined with can be used when there is a contraindications to anticoagulants, which has a role in the prevention of the VTE, as we will see. Also, it can be used when there is complications from the use of the anticoagulant. طيب ده ياخدنا على سؤال مهم جدا. هم ايه contraindications for the anticoagulant in general? You should know them, because if you prescribe an anticoagulant to the patients at this situation, this may lead to catastrophic bleeding to these patients. And this could be a point of question, and this is very important during your practice. The patient is hemophilic, which has, this patient has a bleeding tendency. This patient is subjected to spontaneous bleeding. If you give to the patient anticoagulant, the patient, you could kill this patient. If the platelet count is below 70,000 per minute, there is an active bleeding, for example, or not, intracranial or gastrointestinal bleeding in the past 3 months, and you give the patient anticoagulant, this may rebleed again, or intracranial aneurysm or angioma. Allergy to the heparin, and also some precautions should be given to the patient to adjust the dose, like the liver failure, renal failure, multiple and head trauma, etc. You should revise this and things, these absolute contraindications are very important to you to know. They are a common place for questions in exam. Limitation of the IPC, which is intermittent pneumatic compression, if there is edema due to congestive heart failure. Edema during and congestive heart failure will put the skin at the hazards of irritation and ulceration. Also, there may be a displacement of great amount of the fluid into the general circulation that could lead to volume overload and complicate or aggravate the congestive heart failure the patient already suffers. If the patient is having active DVT right now, this may dislodge this thrombus and produce pulmonary embolism. If the patient has a peripheral, the viability of the limb is dependent on the collateral circulation. This pneumatic compression will interfere with this collateral circulation and leads to perfusion pressure drop in this patient and could have dire consequences as well. The patient suffers infection like cellulitis or erysipelas. The applications of the IPC could be in this patient and cannot be tolerated. It cannot be applied over the limb with bone fractures. This is obvious in such cases. How we use this is it looks like a boot or shoe with a bladder like placed over the plantar aspect of the foot. It can be inflated to pressure of 200 for a short time and it deflates again. It will help to enhance the venous return in the lower limb. It is used when there is contraindications to the anticoagulant and at the same time contraindications to the intermittent compression. How prophylaxis methods? How we should choose? We have said that we have mechanical methods and we have a pharmacological method. Pharmacological method is the low molecular weight heparin. And mechanical methods, as we have said, graduated compression stocking. Number 2, intermittent pneumatic compression. Number 3, the foot pump. Here we do that. برضه الصوت دخل علينا كده مش عارف دخل منين. In order to assign the patient to in the first place, to give this patient deserves to have prophylaxis against pulmonary thromboembolism or not, and which method if he is indicated. We perform the Caprini score, and if we found that Caprini score is 0, this patient is advised to have only early ambulation, nothing more. If the patient is low, this patient is offered intermittent pneumatic compression. If this patient is moderate, low molecular weight heparin or intermittent compression is given to the patient. It's better to be given together. If it is high, low molecular weight heparin or low molecular weight heparin plus intermittent compression or graduated elastic stocking. Caprini score. What this is the Caprini score. I have mentioned.
دكتور صوت حضرتك راح.
كده الصوت رجع كده. the choice of the indications for the prophylaxis and the choice of the method of the prophylaxis depends upon the Caprini score. As you see, according to the Caprini score we have explained to you earlier. Again, details of this are not required from you. Only the principle you need to know. Only the principle of everything. You should understand everything, but you should not exhaust your memory. يعني سامعني ولا لا؟ يا أيها الشباب.
سامعين حضرتك يا دكتور.
اللي بكرره تاني، عايزكم تفهموا مش عايزكم تحفظوا. مش هنسألكم على حاجة محتاجة ان انت تسمعها. الحاجات اللي هتحتاج ان انت تبقى تسمعها حاجات كلها بسيطة، مش كل حاجات. انا عايز اقول لك ان هو العيان عشان خاطر ان احنا نعمل له بروفلاكسس اجينست ثرومبو امبوليزم، اول حاجة بنعملها ان احنا بنعمل الكابريني سكور. بعد ما نعمل الكابريني سكور بنشوف محتاج بروفلاكسس ولا لا. طب لو محتاج بروفلاكسس، كابريني سكور ده اكوردنج للريزلتس اللي طالعه منه تقدر تجايد مي ذس ان انا اديله ويتش تايب زي ما احنا بنشوف اهو. ده لو هو زيرو مش هياخد اي حاجه خالص. لو هو واحد من اتنين ممكن اديله اي بي سي اللي هو انترميتنت نيوماتيك كومبريشن. طب ما عنديش في المستشفى دي، هبتدي اشوف الليفل. خلاص. طيب المودريت بستعمل يا اما لو مولكيولار ويت هيبرين يا اما استعمل الاي بي سي. الهاي بستعملهم الاثنين مع بعض، لو مولكيولار ويت هيبرين زائد الاي بي سي. مش موجود اي بي سي هستعمل جرادويتد كومبريشن ستوب. This is again دي حاجه according to الامريكان Society of the Chest Physicians هم اللي قالوا هذا الكلام، وهم قالوا انه الكابريني سكور to be adopted في الايه في الحكايه دي. برضه احنا عايزين نبقى فاهمين في عيان هيحتاج بروفلاكسس وعيان لا. according لايه؟ according للسكور. There is no matter of guessing. We should not guess to whom I give or to whom I should not give. Because if you miss one patient, the consequences are very grave. This patient could develop pulmonary embolism which could be fatal. You can regret doing that. تمام كده. ننقل على بعده. طيب احنا قلنا دلوقتي ان احنا عندنا الميثودز يا اما في ميكانيكال ميثودز يا اما في فارماكولوجيكال ميثود. هنيجي على الفارماكولوجيكال ميثودز اللي احنا بنستعملهم. طيب الفارماكولوجيكال ميثودز قبل ما نقول which type of pharmacological methods and how we use them, we should put into considerations حاجة واحدة اللي هي ايه؟ هي the balance between the risk of development of the pulmonary thromboembolism against the risk of the bleeding caused by the use of this anticoagulant. To use the anticoagulant, we should use the anticoagulant that has the lowest risk of bleeding type. This should be given to the patient before surgery. Before surgery, we take the surgery as an index incident that lead to the development of the venous thrombosis. Okay. This patient is going to have a surgery, and I calculate to the patient the Caprini score and found that this patient is indicated to have prophylaxis against pulmonary thromboembolism, and I decide to include in the prevention of this patient the anticoagulant use. The benefits of the anticoagulant should the benefit, which I mean the benefit in prevention of the pulmonary thromboembolism, should outweigh the risk of the bleeding. Another point is crucial at the time of the administration of this anticoagulant closer to the commencement of surgery, the risk of the bleeding ايه تاني هقولها بالعربي. لو انا اديت في فتره الريسك لو commencement of the surgery الايفكت بتاعه ممكن ما يبقاش effective to prevent الفينا ثرومبوزس، يبقى لازم تبقى حاجه measured. الانتي كواجلانتس اللو مولكيولر ويت انتي كواجلانتس انواعهم كتير قوي. انا خدت منهم اكزامبل بس. this is the most frequently used اللي هو اسمه انوكسبارين، او احنا كلنا عارفينه تحت الاسم التجاري بتاعه اسمه كليكسان. كليكسان الريكومنديشنز بتقول ان هو يتاخد 40 مللي جرام one single jab or injection of 40 milligram 10 to 12 hours before commencement of surgery, and 6 to 8 hours and anticoagulant in terms of the treatment of the patient to prevent pulmonary thromboembolism. طيب, the duration of the treatment, it has been found that من الفايبرينوجين study that had been performed before, عملوا radioactive fibrinogen studies. They found in 50% of the cases who developed DVT, they developed this DVT during surgery. 50% developed this DVT during surgery. And the risk is continuous for 28 hours of the surgery. If you adopt to give the patient prophylaxis against pulmonary thromboembolism, this should be started before surgery and after the surgery for 1 month following surgery. الجرت العاده كان الناس بتدي البروفلاكس اجينست البلمونري ثرومبوامبوليزم لغايه ما البيشنت يبقى فول امبيولنت. لا، هو المفروض ياخده لمده شهر، حتى ديسبايت ان هو خرج من الهوسبيتال، حتى ديسبايت ان هو از فريلي امبيولنت. طيب، هنيجي على موضوع بقى اسمه الانفيريور فينا كيفا فلتر، نحط عليه ستار كده فوق because the inferior vena cava filter has no role in the prevention of the venous thrombosis. And it has no role in the treatment of the venous thrombosis in the thrombus itself. What is the role of this inferior vena cava filter? Inferior vena cava filter, it prevents the passage of the thrombi through the IVC and up to the lung while allowing the passage of the blood. Yani it will prevent any embolus to reach the lung, and that could be fatal to the patient. But it has no role other than that. Has no role on the treatment of the pulmonary embolism itself or in the treatment of the deep vein thrombosis itself. It has nothing to do with that. When we use it under extreme precautions. Because you put a foreign material inside, has its inherent problems. If you have no benefit from doing that, you should not use it. Therefore, we use it in extreme of circumstances in which, if the patient has DVT and this patient has contraindications to the anticoagulant as well, or if the patient is put on anticoagulants already and develop bleeding complications from that anticoagulant, or if the patient developed BE despite adequate anticoagulation therapy. This means failure of the anticoagulants to prevent the occurrence of the pulmonary embolism, and therefore I should add another factors to prevent this. Could be the inferior vena cava filter. Patients who have already pulmonary hypertension or decreased cardiopulmonary reserve, like an old patient with a problem in his cardiopulmonary system, and this patient cannot tolerate any additive problems to be added to the already existing problems in his cardiopulmonary status. These patients could have an inferior vena cava for the fear, inferior vena cava filter for the fear of the aggravation of the already existing problems in his cardiopulmonary system. IVC filter, this is example of the IVC filter. In the past were placed inside of the inferior vena cava by open surgery. We perform cut down over the femoral vein, introduce this inside of the inferior vena cava, and leave it to hang there by means of the hooks present in its leg to prevent its migration. Two types of this, broadly, two categories of this IVC filter are existing. This is a permanent IVC filter, which is placed inside of the IVC forever. It not intended for removal later on. And the retrievable IVC filter. This can be removed by endovascular use. We resort to this retrievable IVC filter if there is a temporary contraindication for the anticoagulants, like post-operative patients or a patient in major trauma or multiple trauma patient. We put them until the patient, we put the IVC filter until the patient can tolerate the anticoagulant, and then we remove this IVC filter by means of endovascular means, as I will I will show you. This is examples of the IVC filter which are retrievable. They are characterized by the presence of hook or attached to in order to retrieve this IVC filter, as we will see. Yes, this is what's called snare or nose in OOSE. السنير او the nose in OOSE. النوز دي used to capture animals. انتوا معايا ولا رحتوا فين يا شباب؟
حضرتك يا دكتور.
مع حضرتك يا دكتور.
تمام. السنير ده ليه اسم تاني اسمه نوز. الميديكال ترمينولوجي بتاعه اسمه سنير. التراديشنال نيم بتاعه اسمه نوز NOOSE، مش نوز مناخير، لا NOOSE نوز دي اللي هي اللي بيمسكوا بيها الكلاب بتاعت الشارع، عباره عن عصايه مجوفه فيها حبل ويدخلوها في رقبته ويروحوا زانقين بالعصايه على الحبل تروح يتمسك الكلب من رقبته، دي النوز. خلاص. Similarly in the endovascular this is called the snare. This is the medical terminology. This is دي العصايه بتاعت اللي بنمسك بيها البتاع، وده الحبل اللي طالع منها، ده بيتشعلق في الخطاف اللي عامل زي السناره ده. خلاص. ولما يتشعلق فيه كده نروح شادين الحبل اللي جوه اللي هو الواير اللي جوه ومثبتين العصايه، يقوم ده this filter يكولابس. ازاي يكولابس؟ inside this catheter. ازاي؟ بالمنظر ده اهو يكولابس inside this catheter لغايه ما اقدر ان انا اطلعه. خلاص. طيب الكومبليكيشنز بتاعت الاي في سيلتر ما فيش حاجه ما لهاش كومبليكيشن. everything has its price. Therefore the risk benefit should be calculated for each patient before you embark on inserting IVC filter in any of the patients. We have acute complication like the bleeding or thrombosis at the site of insertion. We have misplacement. We put it under the renal veins. Sometime during its introduction, it can be displaced or misplaced in a site that could be dangerous to the patient. The late complication, the filter itself can develop thrombus in this, and thrombosis here will be thrombosis of the IVC. This means compromise of the blood venous return from both lower, as I have said, and I should continue to say this is benefit and risk of this must be calculated for each patient. Also, it can lead to DVT in the lower limb. The filter itself can break or can migrate or can lead to erosion of the vena cava. Like you see this. This is filter. This is CT, and this is the sagittal plane of CT. This is the inferior vena cava. This is the renal vein, as you see. This is the left renal vein. Look at the legs of this filter have gone outside the wall of the cave. This is during surgery, as you see it larger for you. As you see here, this is the legs have been protrude out of this IVC. This is a problem, and this is should be removed by a heroic as you see. Okay. تحبوا تاخدوا حاجة تاني ولا يا شباب؟
كفاية يا دكتور.
تعبتوا؟
كفاية يا دكتور.
طيب خلاص، لقائنا يوم السبت بقى الساعة 1.
دكتور ممكن أسأل حضرتك حاجة؟
اتفضل.
حضرتك ممكن تحط لنا فايل PDF بتاع المحاضرة اللي فاتت بتاعت DVT على التيمز هنا دلوقتي؟
دلوقتي حالا؟
يعني وقت ما حضرتك تفضى يعني.
حاضر. طيب حد عايز حاجة تاني؟ يا شباب حد عايز حاجة تاني؟
شكرا.
طيب
شكرا يا دكتور.
لا يا دكتور شكرا.
نلتقي يوم السبت إن شاء الله الساعة 1 بالظبط. السلام عليكم ورحمة الله وبركاته.
وعليكم السلام.